Hi, I would like to welcome you to our session this afternoon. The right technology at the right time, considerations for aging with spinal cord injury. I said that because the building is so large, I wanted to make sure that you knew you were in the right place. Our speaker this afternoon is Ginger Walls. She completed her PT education with an MS from Springfield College in 1989. She was the regional director for the MedStar National Rehab Network. She has a broad background in neurologic PT, especially seating and mobility. She has been certified as a neurologic clinical specialist from the ABPTS since 1995. She received her certification as an ATP from RESNA in 2001 and as an SMS in 2010. She regularly speaks and advocates in the area of seating and mobility. She is currently a clinical education specialist at Permaville, and we welcome her today and are very interested in what she has to say.
Thank you guys for coming and taking the time to spend some time talking about considerations for aging with a spinal cord injury. And obviously we're all here interested in wheelchairs, seating and mobility, and so we want to talk about the application of that to help those with spinal cord injury age well. Because as we know, as people get older, nothing gets easier, right? I've certainly noticed that for myself, and I don't have a disability. So those with a disability often are even more challenged as they get older. So, and those challenges can relate to skin integrity, posture, fatigue, managing repetitive stress injuries for vulnerable, weakened muscle and joint areas, and then bottom line comes down to function. Those issues can get in the way of function, and when you can't do what it is that you want to do, well, that's not very much fun at all. So where I came from at National Rehab Hospital, we have a motto that's called adding life to years, and that's what we do in rehab, and that's what we should be doing in seating and mobility, is helping people have the tools that they need and the equipment that they need to do the things that they want to do that are important to them, and that's how we add life to years. So for the learning objectives for this time that we have together, I want you to be able to identify 3 impairments or functional limitations specific to spinal cord injury in those that are aging with that disability. I want you to be able to identify 3 different seating and mobility technologies that you can apply or offer to someone to help them address those concerns. And I want you to be able to also talk about 3 important social and environmental considerations to go over as a team, as a rehab team, with including the patient, the user, the end user of the equipment. They're the ones that are really going to need to buy into whatever changes may be necessary, or it's just not going to work out. So those are some of the things that we're going to talk about today, and I'll try to show you some case examples to help illustrate those points. So Dr. Suzanne Groh, who is at the National Rehab Hospital, she's a researcher, did an article that was in American Journal of Physical Medicine Rehab in 2012, and was about aging with a spinal cord injury. And she found that, just to sort of set a background, the most common age for spinal cord injury was 19 years old. So that's not very old. And that 60% of the population with spinal cord injury was under 45 years old, which I now consider to be quite young. So most of the people with spinal cord injury have the potential to live a very long time with their injury, and that's what we want, right? But we want them to live well. We don't want them to just be getting by. We want them to be able to participate and function to the best of their ability. So Dr. Groh's article went on to describe that the mean age of injury has increased It used to be that the mean age was 28.7. Now that's gone up to 40. And the reason for that is there's a bimodal age distribution. That means two peaks. Young adults are often injured as a result of motor vehicle crashes or sports injuries or, unfortunately, violence, whereas older adults over 65 may be injured because of a fall. And so we have two very different age groups that are coming to us in rehab and need our help with their rehab as well as our equipment. And they have very different needs. They have very different fitness levels and comorbidities that they're bringing to their rehab experience. So either way, a phenomenon that we see with spinal cord injury is something called accelerated aging. Who wants to sign up for that? That sounds great, doesn't it? It's where the aging trajectory and rate, the effects of aging are accelerated, and that leads to a narrow margin of health. So these folks with spinal cord injury are more vulnerable to some problems that can ultimately, unfortunately, lead to even death if they're not met, if they're not monitored, if they're not prevented, if they're not evaluated regularly. So because of the physiologic changes that happen with spinal cord injury. So what can we do to ameliorate this condition? We've got to make it go away, right? What can we do as professionals to help these folks with spinal cord injury best not have those complications that might happen? Is there something with the equipment that we could do? Is there something with education that we could do? What can we be thinking about? Is it possible that the equipment that the person is using is even contributing to some of the problems? Thank you for the affirming head nod. Appreciate that. So I want to talk about some of the factors that influence altered aging with spinal cord injury. Now, first one is increased obesity and adipose tissue. Because of lack of standing, walking, moving around, lack of weight bearing, you get some body mass and composition changes in people with spinal cord injury. Muscles atrophy, adipose tissue can accumulate, and that's a problem. That's a problem. Obesity is very common with spinal cord injured folks, and so it's important to consider diet, it's important to consider physical activity and a means of exercise, and it's important to consider the equipment. Sometimes if people gain weight, there need to be changes in the equipment, and sometimes, again, if people gain weight, and maybe certain functional activities like propulsion become more difficult. So there's an inevitable tie-in of weight gain and equipment considerations. Along with the weight gain comes increased cardiovascular risk. Because of increased adiposity in the abdominal region, folks with spinal cord injury have an increased risk for cardiovascular disease. And in fact, ischemic heart disease was one of the leading causes of death in this population. Sometimes aerobic exercise is difficult for these folks as well, so it's part of the concern. And a lot of that's due to sitting. Even in here as you sit for another hour plus, that's not helping your health, unfortunately. So sorry. If you need to stand up, help yourself. But reducing sitting time improves metabolic consequences even in the healthy population. So for folks who have to sit all the time, that's one of the reasons why they have some of these cardiovascular disease concerns. In the healthy population, increased sitting time associated very strongly with increased cardiovascular disease mortality, and the time spent sitting was independent of any physical activity or exercise program that you did. So even if you all got up early and worked out this morning, you're still sitting all day. So sorry. That it's still not good to be sitting for a prolonged period of time. So the public health message here from this article that Patel did is that we should be looking at ways to reduce the amount of time sitting. All right, so I want to go over some case studies to go through some of these points. So I want to talk about some of the things that we need to consider when we're going to make a change or recommend a change in equipment. So if I were to recommend a change in equipment for somebody and just said, here, this is what you need, go ahead, have a good time, good luck, that probably wouldn't go over very well, right? Because I'm just imposing my view, my opinion on that person. I'm not involving them in the process. So it's really important to get a big picture understanding from the client about what their home situation is as far as their environment, what their work environment is. Think about the transportation, whether they're using public transportation or they're driving a car or they've got a van. How is the equipment secured in that vehicle? What are the functional trade-offs? Are there any trade-offs that you have to talk about if someone's moving from a manual chair to a power chair? You betcha. You betcha. So we need to be able to talk about those things. And then we need to decide what the priorities are. There's some give and take, right? When you change equipment, you might give up the transportability of a manual chair because the power chair meets their needs better for mobility and pressure relief. That's a trade-off. So you have to decide what the negotiables and non-negotiables are with that person who you're working with buying into that. If they don't buy in, then you risk equipment abandonment, or you risk that phone call, the dreaded phone call, a month later saying, this isn't working out for me, you've got to take this back. So education is part of this process, so it's important that we understand what the person's vulnerabilities are as someone with a spinal cord injury, what our best practices are, so we can help them make informed choices. So the whole process involves a synthesis of knowledge, right? We need to understand about the person. We gather information during the evaluation. We understand from the patient, what are your priorities? What can you tell me that's important to you, that we want to make sure that this equipment is going to be able to do? We need to understand best practices, like the clinical practice guidelines from the PVA or the resonant position papers. We need to understand the equipment and the trade-offs involved in different types of equipment choices. We want to determine with the patient what the goals of the system are, do the definitive equipment recommendations and ordering, and then bring the person back for fitting and training. That's a process, and if we skip any of the steps in that process, the chances of having a great outcome go down. And so it's important to not shortcut the process. So here's a case study of a fellow who's a 27-year-old guy with tetraplegia due to transverse myelitis. And he had the complication of having a right femur fracture and developing heterotopic ossification in his right hip. So he had a real significant hip flexor limitation. He could get to 100 degrees, and that was it. He had swelling in his legs, and he had skin breakdown on his fibular head areas and his greater trochanters. He had a wound vac on, and all of those breakdown areas on the sides were caused by rubbing on wheelchair parts because he had gained weight when he was in the chair. He was on a lot of different steroids, and that contributed to the problem. He was dependent with his transfers and his pressure reliefs and his ADLs, and he lived with his mom in an accessible apartment in DC. So here's his old chair, and some of the problems that you might notice are the ACE bandage holding the armrest on. That's a concern. And he had, because of his weight fluctuations, he had exceeded the seat size and capacity of his present wheelchair. And again, with the steroids, he was kind of up and down, but he was currently above 285 pounds. So he qualified under Medicare for a heavy-duty power chair. And we determined, because wheelchair disrepair was a real significant problem for him, that a chair that had a greater weight capacity would be a good idea. Now, even though a standard manual wheelchair weight capacity goes up to 300, even with Medicare, you can get someone who has 85% of that capacity into the next size up chair, and that might be a really good idea to improve the durability of the equipment, especially if someone's having weight fluctuations. So that was one of the things that we talked about with Eduardo as we were considering the new equipment. This equipment was broken, the tilt system wasn't fully functioning, the back angle wouldn't open up enough to accommodate his hip flexion contracture, and as a result, he didn't get the postural support that he needed, he didn't get the pressure relief that he needed, and he was not a happy guy. So for his new equipment, we recommended a heavy-duty power chair with a fixed open back angle to accommodate his hip flexion contracture. We got him a Permobil M300 heavy-duty with a corpus seating, power tilt, and power center mount elevating leg rests. He was using we went to a Rojo high-profile cushion, and so that met his needs for his size and his positioning. Here he is in his new chair, and you can see on the side here, this armrest style was open. And so even if his weight fluctuated a little bit, he was going to get a little bit of grace from this equipment because there wasn't an armrest post that he was going to rub up against, especially since that's where he was having a lot of those wounds. Same with the leg rests. This is a center mount leg rest instead of leg rest mounted on the side. So it was going to stay off of his fibular heads and he wouldn't be rubbing. Plus, of course, the seat size and the weight capacity of the chair were more in line with what his needs were. So that was how we helped Eduardo compensate for his weight issues. There he is with a front view. That's his Hoyer sling and the tubing from the wound vac. It kind of looks funny in the picture, but yeah, the Hoyer sling's on the Rojo. Yeah, that's not ideal. When he came to seating clinic, he did not want us to take him off of the sling there. He was more comfortable with getting out of that at home. So, but he could do his pressure reliefs. He could sit at an angle where the back accommodated him. So that at least was a much better setup for him functionally. So bone density complications are another issue that folks with spinal cord injury face because, again, of decreased standing, decreased ambulation, bone mineral density tends to go down, and that results in increased risk for fractures and all of the problems that come with fractures. Heterotopic ossification, the excessive laying down of bone at major joints in the body, usually at the hips, knees, shoulders, elbows, can also be a problem that compromises function and posture and independence. So here's another case study of a fellow named Joe, who's 34 years old. He has a T12 Asia A spinal cord injury and he has HO at both hips. So he's got some really bad range of motion limitations. So I saw him in 2010. He came in and the left hip only flexed 35 degrees and the right hip went a little further to 90. He came back in 2014 and his range of motion had gotten worse, and he had also had fallen out of the chair and had fractured his leg, and so he had a little bit of a deformity in his lower leg as well. He had had skin breakdown problems and had a history of a flap, so he's got a number of different things going on, all because of his posture and positioning. He had pain in his neck. He was dependent with his transfers. Well, I shouldn't say fully dependent. He did help, but because he was in this stretched out position, he could help move his upper body, but he needed somebody else to manage his legs. So he couldn't transfer by himself. Plus, his wheelchair kept tipping over. So this is him in 2010. And you can see He's also got the duct tape foam thing going on, and he's got this piece of foam shoved in there because the chair wasn't making contact with his back. And he's stretched out. He's got his hand and his arm behind his neck because it's helping to support his head because he's all stretched out and he's tired of sitting like that. It makes me tired looking at him. There he is, different angle. So we got him this chair in 2010, and he came back to us in 2014 with this chair, that we had given him 4 years previous. And again, the problems were the wheelchair kept breaking, the wheelchair kept tipping, even though there's an amputee axle plate on here. We had moved the wheels back to try to make it more stable. But he was having problems with this chair. So here's what he looks like sitting in the chair, and you can see why his neck might hurt, why his shoulder might hurt from propulsion at this point. Now you're asking, well, why did you put him in the chair? It was very important to him at the time to stay in a manual wheelchair when we saw him in 2010. He wanted his buddies to be able to put it in the car. He was, this was his thing. It was very important to him. So that's why we did that. But he's not at the position you would want for optimal push rim biomechanics, is he? So, and you can see that the back canes are kind of all up in his shoulders there. So that wasn't comfortable. And again, his neck didn't have any support. There's the varus deformity in his leg. He's rubbing against the hanger on the wheelchair. And his feet are not positioned well. So what we decided with him at this time when he came back was that it was time to transition to power to meet the goals that I listed out for you here. We could improve his postural support. We could accommodate for his range of motion restrictions. We could reduce the shoulder problems that he was having and the shoulder pain that he was having. And we could improve his ability to do his thing, his MRADLs, including his pressure reliefs. He could do that independently with the power tilt. Improve his safety, the wheelchair is not tipping over. That's a plus, right? And reduce the amount of repairs, because the supplier was getting tired of running back and forth, fixing the backrest when it fell off the chair because it was under so much stress. So we dropped him in the power chair. I mean, not really dropped, but we placed him gently in the power chair. And this was just a demo that we had in clinic. And we had opened the back angle up to meet his hip angle requirements. And look how good he looks. His head's supported, his back's better supported, his hip angle's accommodated. His left shoe fell off, but that happened. So that looked a whole lot better. What else do you notice about the position? Sorry? It's got tilt. Yep, we provided tilt for pressure relief. So he tilted himself back, and that way he felt like he wasn't sliding out. What about the weight distribution? That works out really nicely with the front-wheel drive chair with him stretched out like that. He's really over the center of the chair. What else do you notice about Joe? He's relaxed. Yep. What else? He's sitting up better. How does he look now compared to how he looked in the 2010 pictures? Has he put on any weight? Yeah. Back to complication 1 and 2, right? He's got that little cell phone holder now, right? Yeah. So we decided with Joe that his new equipment was going to be a C300 power wheelchair with the corpus seating, with the power tilt that was said, the power center mount elevating leg rests that got the leg rest away from that varus deformity in his lower leg, and he had a headrest and he had a J2 cushion, and worked great. It worked great. There he is from a different angle. And he took to driving like that. He just was so relieved to not be in that manual wheelchair. He said, it was important to me at the time, but now this is what's important to me. So Joe had some examples of increased musculoskeletal wear and tear. And manual wheelchair use can contribute to that, particularly if the chair is not set up well. We need to be concerned about repetitive stress injuries to the shoulder and elbows and wrists as well. So fortunately, the PVA CPGs on upper extremity preservation give us some good guidelines to follow to help our patients and help us help them better. And you can find these on the PVA website. They're free. What's better than free clinical practice guidelines? I mean, maybe free ice cream, but they're great. You can download them. You can load them right onto your computer. You can give them to your patients. It's a great tool. So wrist, elbow, shoulder are all vulnerable areas. I've seen particularly more shoulder injuries. And one thing that's common, no matter where the overuse injury is pain is often a symptom. And that pain in and of itself can contribute to decreased function. So we really need to pay attention to these issues. So a summary of some of the recommendations from the clinical practice guidelines includes, back to education again, let people know, hey, this is a concern. This is why this is important. You need to pay attention to your shoulders because you need them for transfers and you need them from pressure reliefs. You know, we want to protect you so that you can do what you need to do for a long period of time. So maintaining fitness is another concern. And again, back to the balance between use, need for cardiovascular health, and obesity, weight gain. You know, they compound each other and it can be a vicious cycle there. The guidelines suggest that we routinely assess the patient's function. That means when somebody says to you, but I've never had to do that before, well, things may have changed a little bit, right? So you may have to do something differently than you had to do before. And that can be hard to get your mind around. Sometimes it takes me a few minutes to get my mind around something that I may need to do differently. So we need to be able to help people through that mind-changing process. So as far as ergonomics of the chair, we want to minimize the frequency of repetitive upper limb tasks, so reduced pushes, if we're talking about propelling a chair, and reduced force that's required to push the chair. And that can be accomplished by proper wheelchair setup. And then we also want to minimize positions where the limb can be injured, and that might include, don't just get injuries from pushing, people get injured from transfers, people get injured from falling out of the chair if it's not balanced well. So, and then pushing, of course, is another example. But avoiding extreme positions of the wrist, which often includes full extension, and internal rotation and adduction. Guess what you do when you transfer? All of those things, right? All of those things. So helping people learn safe transfer techniques is something we can do in PT and OT, and that's a good thing. It's a good thing. Or using equipment to help transfer. Or considering the equipment that they're using, and maybe they do need to think about a seat elevator, even if it isn't a covered item. So with high-risk patients, discussing the pros and cons of changing to a power wheelchair if repetitive stress and propulsion is a problem is an important conversation to have, like we did with Joe in the last example. If the person is going to be a manual wheelchair user, those folks need to have an ultra-lightweight wheelchair that can be made to measure to their dimensions. So frame length is important, as well as the size of the seat and all of the accessories set up in a configuration that works best for them. The rear axle needs to be adjusted as far forward as it can while maintaining stability of the chair. And that's going to vary person to person based on their skills and their individual balance and their needs. But that's an important adjustment to make. And if we're providing K5 chairs and we're not adjusting the axle, then we're missing the boat. We need to make sure we're setting the chair up right. So this is an example of a chair the axle is actually forward of the user's hand. He's got good wheelchair skills. He's got good balance in the chair. It's about at hand level. That's what you want. Fingertip to axle plate is one measurement. In his case, he's actually getting a little bit lower, which is good for him. If people can sit down in that chair, they'll have a lower center of gravity, and they'll have more of a gear, more of a torque when they propel. So the other measurement is with their hand at top dead center of the push rib, that the elbow angle is about 100 to 120 degrees of flexion. So, and then we need to educate the patient about pushing. You don't get far pushing like this, right? That's high frequency and without much result, without much roll. So we need to teach a circular pattern that's used. You've seen the wheelchair racer guys, they push, they drop, push, drop, release, so that they get maximum roll with minimum repetitions. And we want to make sure that the wheelchair user has an appropriate seated posture in the chair, so that they have the best stability, that they're not hanging onto the armrest because they're afraid they're going to fall out of the chair. So it's, push, grab on, or I can only push a little bit because I'm afraid I'm going to fall if I move my body out of a certain area. And we want to make sure the wheelchair is stable. Some people don't want to push hard because, my wheels come up off of the ground, or I'm not stable. So we want to make sure that the chair isn't rearwardly tippy or frontwardly tipping. And not everybody checks this with wheelchair setup. This particular fellow was an elementary school teacher. So being able to reach to the floor was really important for him. Being able to be down at the same level with the kids he was working with. And he was able to do that in his chair because it was set up properly for his body measurements, not just the seat depth, but also the frame length. And then if the person's really high risk, they may need power. High risk patients might be somebody who's obese and it's harder for them to push, or their arms are more abducted when they're pushing. That's not in a great advantageous position to push. Or they may live in San Francisco and have a million hills. I remember the first time I went to San Francisco, I thought, how could anybody be a manual wheelchair user here? This is nuts. But I've certainly had patients who live in areas where there's steep hills, and that's something to think about. What will their environment be? What are the advantages of power? If you're having to discuss with a patient, switching from one to the other. Less repetitive stress, more accessibility. What are the disadvantages? What are the trade-offs? Accessibility, transportation. Yeah, those are some trade-offs. Sometimes there's a perception that there could be an increase in weight. That's a give and take. Well, because guess what? If you hurt your arms, you're not going anywhere anyway. So there's a trade-off there. Wheelchairs aren't necessarily, they're first a mobility tool. Exercise may be something that people want to pursue. There's great wheelchair sports and opportunities, but we have to make sure that day-to-day life is taken care of first, for sure. And then back to equipment selection. We always need to make sure that the person has optimal posture alignment of their trunk so that they have good biomechanics when they roll. If the person's kyphotic, they're more likely to be impinging their shoulders, and so we want to make sure that we position them well in the chair. And then for people who are having trouble with overhead reaching because they've had a rotator cuff tear and their shoulder's compromised, or it hurts when they reach overhead, we might want to consider seat elevation or standing to help get them up to that height where they need to be. So in any event, as I said before, without a thorough assessment of the patient's environment, we can't really get to the point where we want to be in understanding the needs to provide the right equipment. And back to the transfer training piece, we need to help them perform level transfers whenever possible. I always ask the patient, How high, tell me about the height of your wheelchair. Is this a good height relative to your bed? Do you need to be higher? Do you need to be lower? What would that do to your environment? Do you need to be able to change positions? Sometimes using ergonomic push rims can help, with the grip and repetitive stress. But whatever it takes to improve the ergonomics of the chair and the ergonomics of the environment, we need to be thinking about. Okay, so here's another case study involving some problems with wear and tear on the shoulders. So Bill is a 60-year-old guy who C7, C8, Asia A tetra due to a motor vehicle crash in 1982. So he's been a spinal cord injured fellow for a while, since 1982. Do the math. That's significant. He's 6 foot tall and 220 pounds. He's complaining of bilateral shoulder pain, and he's come to PT to help deal with the shoulder pain, and he's had platelet PRP injections to his shoulders to try to address the pain issues that he's having with both his biceps and his supraspinatus tendons. And his problems, his complaints are pain with propulsion, transfers, getting dressed, getting in and out of the car, pretty much everything, right? And also getting the wheelchair in and out of the car, breaking it down and putting it in the back of the car has become a problem. And he was really proud, I've been able to do this since 1982 when I got injured, and now I can't. What am I going to do? So those are some tough decisions that he had to face. So finally, he went to a convention, and the hotel bed was at a different height, and he tore his biceps tendon transferring into the hotel bed. So conventions can be hazardous to your health, so beware. That's what a torn biceps tendon looks like. It was a nasty tear, and that really laid him up for a while. So the changes that Bill made, he came back to PT for treatment, and he said, okay, I want to try those power assist wheels. He already had an ultra-lightweight manual wheelchair, so we put the power assist wheels on, and he was able to propel without pain. He also decided he was going to purchase a van to make the transportation easier. And he's like, oh my God, I wish I'd bought this years ago. This is so much easier. He continued to use the same cushion and back, so that didn't change. So the main thing that changed was adding the power assist wheels and him buying the van. Huge changes for him, but they made such a difference. And he said, my family was visiting, and the grandkids were here, and we were going to take them to the zoo, and I didn't hesitate to go, and I couldn't have done that before. So that's an important participation element that he would have missed or had difficulty with if he hadn't been ready to make that change, but he was ready to make it. Unfortunately, it took that nasty tear to get him there, so it's greater when you can be proactive instead of reactive, but nevertheless, he's still able to do the things that he wants to do. Yes, sir, question?
The interesting thing about going to that type of step is it allows him to make that big change with his transportation device. So in the event he had additional problems with his shoulder, the transition to power would be relatively simple at that point.
Right.
Because his manual chair was no longer folding because of the locking device for the van. He has the weight of the power wheel, so he couldn't lift it. So he had to make that transition
To the van.
to a device that wasn't going to fold it.
Right. The comment was that Bill's change to the van and to the power assist push rims simultaneously makes, if Bill needs to change to a full-blown power chair later, it'll make that transition easier because he's already got the van in place. Did I restate that correctly? And he's that much further along, so he's prepared. It's a Boy Scout. So when Bill came in to get his new power assist wheels, we had to do some training. It's a new device. He's been pushing since 1982. That's a long time. But he had to unlearn how he had been pushing, and we had to really take some steps to teach him how to use this chair, how to use it on hills, level surfaces, and hallways. And I had to keep telling him, stop pushing, because he was just pushing with the normal cadence that he had been pushing with. I said, stop pushing. Let the chair get you there. That's the whole point. So I want to show you a video of him kind of getting the hang of this. He's pushing into the doorway here, and see how he's keep pushing? And I'm yelling at him, stop pushing. Then he goes into the wall. It happens. And so he's like, okay, I'm going to push once, and I'm telling him, let go. See how far you go. Push again, let go. And he's having to resist the temptation, resist the habit of continuing to push. So the training is really important to emphasize how the equipment is supposed to be used to help somebody. Skin breakdown. Skin breakdown is a very prevalent problem in spinal cord injured patients and in all patients with neurologic compromise who are using wheelchairs. Is it inevitable? No. Not everybody has to have skin breakdown, but they're at risk. So we need to do some things to make sure that that doesn't happen to the best of our ability, or at least that the equipment doesn't contribute to the risk. So we need to, again, follow the advice in the PVA CPGs on pressure ulcer prevention for monitoring skin breakdown, monitoring skin, doing pressure reliefs, and using the proper equipment to make sure that people can achieve adequate pressure relief regularly and functionally in their life. So here's the PVA CPGs on pressure ulcer prevention. They were just updated in 2014, and you can get those online as well. The bottom line is an ounce of prevention is equivalent to a pound of cure. The cost of pressure ulcer treatment is staggering, if somebody has to go to the extreme of having a flap surgery, compared to the cost of any equipment that is available to prevent it. So we need to provide the patient with a regular evaluation of their support surfaces, because the cushion that had worked before may not be working now if they're coming to you with pressure problems. What's changed? What's changed? Is it their ability to do pressure reliefs? Is it their ability to transfer has changed, and now they're kind of dragging their butt a little bit when they transfer? What's causing the skin breakdown? Now, we know the areas that are most common. It's over bony prominences, right? Well, bony prominences are at risk both in bed and in the chair. And oftentimes, when people have come to see me, we sort of figure out, well, where's the skin breakdown? Well, let's look at your seated posture in the chair. And you think, well, that area is really not getting, subject to pressure or shearing in the chair. And maybe it's coming from the bed, or maybe it's coming from transferring. So it's important to kind of go there and delve into how they're interacting with their environment all day. Nevertheless, we want to make sure that we're prescribing wheelchairs and support surfaces that meet the person's individual needs and measurements, and that we're using appropriate cushions, the best ones that we can find, to help them meet their needs for both pressure reduction and postural support. And there's lots of great cushion options out there, fortunately, because I think the last presenter said there is no one cushion that's right for everybody. That's true. There's lots of different kinds of butts out there. And we need to assess the full seating system support. If they're leaning off to the side and they need more trunk support, or they need a position change in the chair to give them better balance so that they don't lean, those are all factors that can contribute to skin breakdown. So the other thing that's critical besides the posture is that we need to make sure that they have a way of doing pressure reliefs consistently. If they can say, yeah, I can sort of lift myself up, or I can lean over, but it requires a maximal effort and it hurts, then they're not going to do it. So someone who can't do an adequate pressure relief in a manual wheelchair may need a power wheelchair. Another alternative is that there are manual wheelchairs that are manual standers. Standing is a reasonable pressure relief. If they really want to stay in a manual wheelchair, but they can't lift themselves up, they can use a manual standing chair. But oftentimes people at this point choose to transfer, to the next step and move into power. And then again, back to education. It's so important that people understand why they need to do pressure reliefs, when they need to do them, and why it's so important. Generally, the guideline is to do a weight shift every 15 to 30 minutes to get maximal oxygenation to the tissues. People who are more active can get away with not being as vigilant about doing a full pressure relief because they're moving around a little bit more. If you have an active para, he or she is probably moving around and shifting their weight in the chair a little bit more than someone who is very static in their position. If a person is a tetraplegic and they cannot move at all, then those are the folks that really need to be vigilant about doing a full weight shift to relieve pressure. So follow-up training is really important so that people understand what a full weight shift is. Some people are scared to death to tilt and recline all the way back in the chair. Anybody had one of those folks? Yeah, it can be scary if you haven't done it before. I had one poor lady, I felt so bad. She cried, "Please don't make me do this. You gotta do this. It'll be okay." And so, I do it with them in seating clinic. Go all the way back. We're here, you're gonna be okay, so that they can experience that and see what it's like. Sometimes they do go back, and not only is the angle not sufficient for full pressure relief, the duration isn't either, or the frequency is insufficient. So all of those things need to be taken into consideration. There are some tools to help with compliance or strategies. You can look at setting a timer on your smartphone. You can look at the virtual seating coach application that's over in the Bimodal booth. That's a pretty cool tool to monitor. Are they going back far enough, and are they doing it frequently enough, and providing reminders? You can look at setting memory, seat functions, or the independent repositioning mode. That's a preset angle, so if the person gets tired of holding the joystick or holding the button to go all the way back, that you can even latch the function, so you could pre-program the position of optimal pressure relief in tilt and recline together and say, hit this button and you're going to go there. And then you don't have to worry about holding the time on the switch or on the joystick to get there. Sometimes that's what it takes. And then you want to check, once they get all the way back, can they get up? That's a really important thing, because nobody wants to be stuck back there all day. At some point, we want to get back up again. And then consider standing as an alternative way to do pressure relief. One of the reasons that, I want to make sure I didn't skip a slide, okay. One of the reasons I think that people don't tilt back far enough and maintain that or do it often enough is that it's not really a very functional position, unless you want to take a nap. So if you want to take a nap, that's a great position. But otherwise, it stops you from whatever you're doing in your day, and you need adequate space. And if you're at work and at your desk and you feel kind of out of place doing that full tilt and recline, but standing is a more normal thing and provides great pressure relief as well as some other benefits. So that's something to think about. So dynamic seating systems are important for pressure relief, but they're also important for seating tolerance. Some people just have a difficulty being up for a prolonged period of time, and so sometimes people do need to be a break, and that would be a good time to tilt and recline all the way back. Some people get dysreflexic sitting for a period of time and need to tilt all the way back. So those are other considerations. Here's a case study kind of illustrating both of those. So Henry is 50 years old, and he has a C5 injury on the right side, but he's T4 on the left. So he's very different in function and strength from one side to the other. And that caused some postural problems, because he's got a scoliosis because one side is just stronger than the other. And then he also had a complication where he had osteomyelitis to his right leg and ended up with a amputation, a BKA on his right side. He is a very active, busy man, and he has dysreflexia symptoms by the end of the day, like spasticity and sweating. And he has redness on his skin at night. And when he gets home from work, he has to get out of his chair and lay prone all evening long. Well, that's a heck of a routine, just because of the problems with his skin and the problems with the dysreflexia. Plus, he's having increasing shoulder pain with wheelchair propulsion and doing his MRADL. So here he is, this is his current equipment that he is having these problems in. So he's already got the power assist push rims. He's already got that, and he's still having these problems because his seating tolerance is going down. So he's a full-time government employee. He's very active. He drives his own van, 6'3", 195 pounds. So this is his present equipment, and he fits right into your example. What we ended up recommending for Henry was a power wheelchair. So we got him a C300 Permobile with tilt and recline and center mount elevating leg rests and a seat elevator to help with his reaching. He had good lateral trunk supports because of the scoliosis and hip guides, and then he continued to use his ROHO, and that's really increased his seating tolerance over the day. Now, he already had his van, so the transportation wasn't an issue. He just had to get used to using the new device. So here he is in his new device, he shared with me that it did take him a while to get used to using it, but that he did find that his symptoms went down afterwards. So bowel, bladder, and breathing. These are other areas of complications that individuals with spinal cord injury have. Repeated UTIs are often an issue, as is constipation. Why? Because they're sitting, bladder's not emptying, or they require repeated catheterizations where, again, you're susceptible to UTI. Without standing, the bowel function they don't move around as well as when the person's up and vertical. Sometimes gravity is your friend, right? And sometimes it's not. And then pulmonary insufficiency. The diaphragm does not have maximal excursion in sitting compared to standing, where there's more room for that to happen. And so that can cause problems leading to respiratory infection, pneumonia, which can be a problem for someone who can't cough well, too. So those are important to remember as complications, as is depression. This is often overlooked, but depression rates are higher for people with spinal cord injury than the general population, but they vary with the age of the person and the time that's elapsed since the injury. The risk of depression is highest in the first 2 decades after spinal cord injury. In other words, the person experiences a loss, with the spinal cord injury, has to make that adjustment, makes the adjustment, and copes well with it until there's a new loss of function with aging, and a change needs to happen. And that's, again, a time when we can help and we can intervene. Function and participation impact with spinal cord injury is something that we also need to think about and has direct implications to our equipment recommendations. As someone ages with a spinal cord injury, just like in the normal population, you might have more health problems and comorbidities that creep in, and you see an increase in use in the medical system. We have to go to our doctor more frequently as we get older. And lifestyle, environmental, and employment factors also impact participation for those aging with a disability. They want to keep working. My parents are getting older. They're in their 70s, but they like to keep working because it keeps them involved and participating. It's no different with this population. They're just faced with these challenges a little bit earlier, and so we need to think about how we can help them do that. Unfortunately, low income is also a factor because it can impact the person's access to equipment and to health care. So there was a study done that looked at access to equipment and found using the PVA CPGs as the standard of care for that an ultralight manual wheelchair or a group 3 or 4 power chair would be provided to an individual with a spinal cord injury, that Medicare beneficiaries and the uninsured were the least likely group to get the standard of practice chair, to get that ultra-lightweight wheelchair, or to get that multiple function power chair. So does that mean that does that mean that we are providing technology based on the payer group or based on the patient needs? You know, we need to think about what's driving our practice. What does that mean for access to optimal technology for people aging with a disability, people coming into Medicare? What does it mean that they need to do, or that we need to do as an organization or as a group of professionals? It means that sometimes we need to advocate. It means that we need to speak up, and people who are in wheelchairs need to speak up and advocate for the right equipment and explain why it's important, why it is medically necessary, and why it is functionally necessary, and what impact it has on life. Here's a case to talk about that. A fellow named Robert, he's a young guy injured at 14 years old, C5 Asia A. He's now 32, so he's had some significant aging with his disability already because he was injured at a young age. He is an artist. He paints using his mouth, and he does stand-up comedy. So fortunately, he has a stand-up power chair. And it's over 10 years old now, so it needs to be replaced. But as a result of the equipment use, he has reduced spasticity, he has increased bone mineral density, his bowel and bladder function and breathing are improved with the use of the standard. He has improved community participation, he's working, and now he's trying to get this equipment replaced and funded, and that's a challenge, that's tough. You have to be willing to fight the fight. So here he is, fist bumping with Senator Ben Cardin from the great state of Maryland in the Senate office building. He participated in the NART's SELA event last year, and so he got to speak to his senator and tell him why it was important. And wouldn't you know, as a result of this visit, Senator Cardin signed on as a supporter of the bill. So yeah, isn't that awesome? We can all do that. We can all do that. Whether you go to DC to do it, or whether you go and just write an email, you know, make yourself heard. It doesn't take that much time, and it's very rewarding, and it's very important. So thinking about Robert, thinking about our whole social milieu and context, things to think about are relevant to aging with spinal cord injury include the current chronological age of the patient, their age at injury, right? He went from 14, now he's 32. So the duration of the injury, the age cohort, or the social, economic, and medical context around their individual picture, their individual spinal cord injury, their big picture. What's their big picture look like? How does the big picture change for all spinal cord injured patients as equipment improves? You may have noticed, those of you how many people have been providing equipment or involved with this for more than 20 years? Has equipment improved? You betcha. You betcha. So that makes a big impact. So does the ADA. We're at the 25th anniversary of the ADA this year. So that helped make the whole environmental context of the world that we live in more accessible for everybody, which is a wonderful thing. Unfortunately, funding lags behind that. So we need to speak up, and we need to have a voice about that. It would be great to see some long-term use studies of people in wheelchairs and how that affected their individual outcomes. So for anybody that's a researcher, that would be a great study to take on. I wish I had that skill, but I do not. We do have the ICF model now, and in terms of looking at the big picture around somebody's injury, we can see that down here, wheelchair specifications and equipment type does have an impact in the person's overall health and their overall participation. There is a big picture. Everything is connected. So maybe some of these complications of spinal cord injury with aging could really be ameliorated, really be reduced with some equipment earlier on after the person's injury, so that over the long term, they don't have as many of these other secondary complications that they have to deal with. I want to show you another case study. This man is amazing. This is Ed Eckenhoff, is the president emeritus. He founded the National Rehab Hospital where I worked for most of my career. He's 70 years old. He was injured as a 20-year-old, so he's been 50 years injured. He's super active. He founded a hospital. I couldn't found a hospital. Are you kidding me? He's a T12 Asia A injury, and his only complication since his injury was he fell brace walking. He's been brace walking for 50 years. He's the only person I know who's ever done that. I know brace walking is not a long, realistic thing for a lot of people to expect to do. But it's interesting that someone who's, put his body, maintained his fitness level, experienced the dynamic loading on his legs, experienced being active, has been able to do so well for so long. After his fall, he had an ORIF of his fractured leg, and the only changes we had to make in his technology after his fall were he needed some different pair of KAFOs and shoes because his legs were now a little bit different in length, and we need to put a wedge under one side of his office chair because he sits in an office chair at his desk, so we made a little lateral wedge, put a Roho pad on top, and that keeps him in line, again, because of that hip joint being different than the other side. He got 2 ultra-lightweight wheelchairs. Again, he can afford it. He's the president of the hospital. And he keeps one at his place in Florida and one in D.C., and he really only uses those after he's played golf and is tired. So otherwise, he brace walks, and when he's at the hospital, he uses a scooter to get around. That's his equipment that's worked for him. I don't know anybody else like him, but here he is standing at the age of 70, independent brace walker. But not for all of his distances. That's why he uses the scooter in the hospital. He'll walk from his office to the car, or use the scooter to get to the car, and then transfer out. But he's tremendous. So his keys to success, and again, I'm thinking about cohort here. His father was a doctor, his mother was a nurse, he was a competitive athlete, so he's always pushed himself. He was, hospitalized 50 years ago, and while care standards, were very different then, he was in the hospital for a long time, and the expectation for him was that he was going to get up and go. So he graduated on the dean's list from college. He's had the financial resources to access equipment and services. He married a woman who's an OT, so he's got kind of all the bullets that you'd want somebody to have to succeed, and that's certainly helped him. And then he's had access to rehab professionals who can help him to continue to be as active as possible. Some of us think that that's why he built the hospital, so that he could come and get care. But the message is, don't fall into the trap of settling for limitations. Don't get in a habit of providing equipment just because, it's what's funded, it's what's easy. Have a reason. Have a reason. Think about what the optimal health benefits of the equipment are for your patient, what their risks are, and provide the equipment that's going to meet their needs in the long term. So practice best practice is what I'm saying or suggesting. Believe in what you do. Know what the best practices are. It's our responsibility to provide those, to translate that into the equipment that we provide for patients. So believe in what you do and do what you believe. Let best practice govern your equipment provision, not necessarily funding. Because Funding policies and best practices are not the same thing, in case anybody hadn't picked up on that. And you have to be willing to be and ready to advocate for your patients, to write the appeal letters, to go to bat, to explain to the patient how to use an ABN. It takes extra steps, but it's really important. I'd certainly want somebody to do it for me or for my family member. So again, back to the NRH motto of adding life to years. With the right equipment at the right time, people can be as active and functional and participate as much as possible over the long term. So, what Ed would say is, if you don't shoot for the 12th hole at Augusta, you're never going to get there. So here he is. Isn't that cool? So it could look like this, or it could look like this. Either way, you get there. Either way, you get there. That's all I have. Questions from the group? Yes, sir. The slides were available online. I submitted a handout that you can upload. So yes, that is available. Other questions? Bueller? Oh, there's one here. Don't be afraid.
Yeah, you talk about standing, the benefit of standing
Yes.
a lot. If someone who has been in a chair for quite a long time and therefore was interested, what do you do? Do you get them to do bone density test, or what would the clinical response?
Okay, so for someone who hasn't used standing for a long time and who's been in a chair for a while, it is a good idea to get a DEXA scan, to ask them to see their doctor and get permission to do that. The funky thing there is, though, there's no specific number that's a guideline for bone mineral density. The physician still has to make a judgment when they're looking at the x-ray of, yeah, this looks good, or no, not so much. So there's a clinical judgment factor as well. But range of motion is also important. I recently had a patient who'd been injured about 8 to 10 years, and he was a fairly young guy. He was in his late 30s, I'm going to say, and he really wanted to stand. He had kids. He was thinking ahead. He was thinking about, gosh, my son's football game. I'd like to be on the sideline. My daughter's wedding. I want to walk her down the aisle. I work. I do things. I want to be participating. I want to stand. So we got permission from the doctor. He felt that it was going to be okay for this particular guy. This guy had a lot of spasticity, so he did have muscle activity because of the spasticity, stressing his bones, so that could be a factor. And he was healthy. His range of motion was good, and so we got him in the stander to try. And his first time up, he was like, whoa, I feel tingly. He was a little dizzy, so it can take time to get used to the physiologic demands of standing. Remember, back at the beginning, the physiologic demands of standing are greater than that of sitting. That's why all of you are in big trouble. You've been sitting here for a while. So it's important to give people time to get used to a device, to see if they're going to be successful at it. If the person can have it, a lot of times, most seating clinics don't have a standing chair there, so you have to pull in, get some help from a rep to bring the chair to the house, and it's going to take it's going to take an afternoon for sure for them to use it. Maybe try it again. Maybe they need some work in therapy first. But again, if they're willing, if they want to do it, then I think you can get over those hurdles. Other questions? Yeah. My lady with the mic is running to you.
Hi. I was just wondering if you've had success getting insurance providers to fund seat elevators, or when they're denied, what the next route is that you typically take.
Yeah, this is really the hard part. And it depends is the answer as far as the insurance companies, right? There's some that say it flat out, it's not part of the coverage policy, we're not going to do it. Then sometimes you get that denial and there's a secondary insurance that you can go to. Or the patient is willing to sign an ABN and say, I'll pay for this upgrade, my insurance will cover this much, and that gets me most of the way there, and I'll find a way to raise money for the rest. That's what this guy that I was just telling you about did. Sometimes you can work with the dealer or manufacturer to help with the pricing, depending on, if somebody has a demo to sell or something like that, that can help bring the price down so the patient doesn't have as big of a reach. And then you have to be ready to fight the appeal process. So you get your first denial, you find out what it says there specifically, and then you use their language that the insurance company is using, and then you can present your argument. I know with Permobile, we're developing a standing resource. You will be able to go online and get information about appeal letters to help you write them, as well as LMNs, as well as research studies on standing, so that you have that ammunition to go get them. Yeah. Other questions?
In your clinical experience, I'm sure you must have come across some quads, we call them like super quads, that hook their hands for stability.
Yeah.
And in providing back support for them after a while, there's resistance to actually get a high support just because they have to hook. Like, what do you do in such situations?
It's really hard. You don't want to take away somebody's function. And if that's how they do a certain activity, then, finding a way to make that happen is important. I've never won the battle of saying, well, you just can't do that, because they need to do it, they want to do it, they're going to do it. So I had a guy who was a tetraplegic, and he needed a higher back. He had some bad scoliosis, and we just had to have the back be a little bit lower than I would have for everybody else, and make sure that the push handle was in a place where he could get to it on the one side that he did hook. So there's some compromise. There's some compromise sometimes. Sir.
Hi, my name's John. I'm with Shoppers Home Healthcare in Calgary, Alberta, Canada.
Hi, John.
Hi. I have several clients in the community that would highly benefit from power mobility for the reasons that you went over today, but they're very reluctant to make that step. And I'm just wondering if you can offer some strategies or ideas or suggestions how to help them make that leap without sort of pushing too far and overstepping our boundary.
Mm-hmm. I've had clients who, are on the fence about, I want to stay in a manual wheelchair, I may need to go to power, and they want your opinion, so sometimes I give my opinion if asked, and then I follow it up with a suggestion of, how about if can we set up a way for you to try this for a couple days? And sometimes that helps them make the decision. They can use that power wheelchair in their home for a while. If we're really thinking long-term, this would be a better solution for them. They can use it for a little while and see, gosh, when I get on this carpeting, it is a whole lot easier for me than when I'm trying to push on it. And they just need to sort of see how it's going to integrate and how it's going to work in their lives versus making a snapshot decision in a seating clinic. Some people just are mullers, they've got to mull over the decision, and that's okay. It's a huge decision. So I've found that having a demo in the home for a little bit is a good way to make the decision. Or they may find out, I can't fit this in here, it's just not going to work, and that's fine too. At least you get a solution that they're going to be happy with in the long term. It's a great question. Another great question. You getting your workout today? Yeah, it's okay, walking's good for you.
My name is David, and I'm with Superior Mobility in Southern California. And so, more to comment. First, thanks for being optimistic. One thing that I've been doing this for 33 years, and we need to be more optimistic. And I'm sorry to say that I hear so much pessimism at this function a lot of times, and it's all about funding. I think we're the professionals, And so what you're saying today, and the fact that you included a couple slides for people to see, especially a lot of the therapists, that look a man, the doctor, and the artist, look when they took a very progressive, proactive approach to their life. Look at what the differences is. And the problem that we have is everybody wants us to go after funding, or for us that are ATPs, we're not salespeople. You know, many people just go out and sell a chair. And what you said at the very end, I'll do that a lot. I'll loan a chair out for a couple of days. It's the best thing you could ever do, because somebody then in their own terms can do that. But I mean, being honest with people and being more real about things, and you can do it empathetically where people understand it. People want education, and we're the ones that are the professionals that should be doing that, and it's not being done enough. And so, I mean, again, I love your approach and what you said. I've got a quad right now that I've worked with for 25 years, and she now has got the real big problem of her skin has gotten so flaccid, and there's just no muscle whatsoever. She's lost everything, and she's got a pain now that is just hard to explain. So I'm allowing her to try a lot of different things, and I mean, it's the only way to go, because we don't know what's next, and to attempt to avoid from surgery. So again, thank you for that. Last thing is that I think that standing is incredible, and the one therapist was asking about the patient lift. I mean, me as a dealer, they're $2,800 retail. I do a lot of permabill. We sell them $1,000 off at $1,800. We've taken them down to $1,600 for people. We've done even payments. Any way to get them that extra feature if they need it. I think many of us should be doing it a lot more, and all we have to do is get denials, and we can do it for everything. So the insurance world doesn't pay real well. But when you offer it to people and explain it to people, they are willing to go. To me, I'm finding, it's one thing I didn't do enough of when I was younger in the field. So don't be afraid to open up your mouth and share with people, because if you don't, they don't know.
Thank you for your comments. Yeah, there's nothing better than the grateful patient, and then they'll be your patient forever. They'll be your patient forever. You'll keep those people. Yeah. Yeah, yeah. In many cases, it's really not complications of spinal cord injury, it's complications of sitting, if you think about it. So